Hi, hi. How are you?
Hello, hello. How you doing this morning?
Oh, another day in Houston paradise. It's like 80 degrees out, and it's February 21st. So here we are. How about you?
It's 60 degrees, and yesterday we had this like insane rainstorm to where it was like I had to turn around and come back home because just driving to work there was so much rain I could barely even get on the freeway. So it was insane. So very different weather
I
than
meant
you.
all we, here we are. So
I love your shirt.
well,
It's pretty. I love your shirt.
we kind of match. Right? We're like color coordinated, very
Yes.
like kind of wintry colors today. So
I
and I'm so excited to be here. I feel like we've had some amazing lunch and learns lately, and I would love for us to kind of break down, so to say, our recent lunch and learns and go through them. And then, of course, to answer lots of questions today. I also want to point out I went traveling this past weekend and I realized, Chris, how old I am. Because did you know that all the young hip kids, you probably know this because you're hip and you are in Hollywood, but wear like real headphones again and
I
they
know.
wear earbuds. And I didn't know this. And so I was walking through the airport, you guys, and I was just like, why is everyone wearing headphones again? Like this is so weird. It's 2024. Why are they doing this? And I noticed they all had the same ones, and I had to Google what they were, and I was just like, wow, this is my realization of my age for the first time where it really hit me that it was like, yeah, Liz, like you are not hip. You don't even know what's happening. You have to Google because you see it on the masses. So here I am, February
Liz, I'm like
2024.
I'm like your cool friend. So you got to text me and then I can tell you. I could say, look, they brought him back. They brought him back.
Man, yeah, I texted my niece and was like, well, do you have these? She's like, they're the best. I'm like, you didn't think you should tell me like some of this hip lingo? She's like, don't worry. When your girls get older, you're going to be the hippest mom because they'll keep you up to date. I'm like, well, what about until then? It was going to give me info or deets. Anyway,
I know the
guys,
crazy thing now
headphones are
too.
back. Real legit headphones are back.
Yeah, the other thing that's really crazy is like skincare now for like preteens. So they're going to Sephora, they're going to Ulta, they're getting the like different brands, the Ordinary. I think there's another brand that's popular for that age range. And I'm just like, okay, skincare at 10. Like these kids are never going to age. They're going to look like 12 when they're 80. So.
They're onto something there. This is smart. So here we are. Anyways, it is 2024. We're going to give y'all all your skincare and headphone advice, and we are here for it. And we're going to help you guys stay young and hip because evidently I am not. So that's that. So let's talk first, Chris. I want to hear your thoughts of just like, oh, let me give our quick disclaimers. Welcome. So excited to have y'all on our stream. Please remember this is intended to be educational and not replace therapy. You should be working with an individual therapist for your own specific questions. Of course, if you're feeling unsafe or suicidal, IOCDF is not a crisis line, but there is crisis lines available to you. If you live in the US, you can call 988, go to your local emergency room, or follow emergency instructions wherever you might live. Let's hop in. Chris, tell me a little bit. We've had a lot of guests on. We've been talking about a million topics. I want to hear your thoughts about like just what's sticking with you, what you feel like has gone really well, where you're at, etc.
Yeah, I was thinking about it. The two lunch and learns, like the two lives that we've done that really stuck out to me I would say the first one was the one that we did with Michelle Massey on core fears. And it really I think the biggest question we get from new clinicians is about the whack-a-mole. I have a client that does really well, but then, they leave treatment and then they come back because something new. And I really like how we laid it out in that live stream. And I was really appreciative of Michelle's kind of insight about really seeing like, what's that core fear? What's underneath? What's driving it? And then obviously having Michael Wheaton on talking about, it's really talking about inhibitory learning and like replacing fear memories with new memories and how learning is part of treatment. So I would say like those two live streams that we did stuck out the most. And then just in like my groups, that's where I always kind of figure out like what people are really struggling with. And I would say like the two things is relationship OCD has come up a lot. And I think because it's a newer subtype, it's a subtype that the two researchers from Israel really put out in 2014 some research on. So it's newer. And then procrastination. I think that A lot of times people with OCD procrastinate because we get in such a habit of avoiding any kind of stress or anxiety. And so things pile up. So I would say like those are the topics, but I really like the live streams. And if people haven't watched them, always remember you can go to youtube.com/IOCDF and catch all of the replays of these live streams, as well as if you go to Facebook and go under videos. But I would say like the core fear and the inhibitory learning ones really stuck out with me, and the playbacks have been great numbers because I think it really resonated with people. How about you?
You know, for me, I agree. I loved both of those. I think the core fears is so important. I see some people talking about them. And then I also really did love inhibitory learning. I made our whole team here watch it and then think about it, and for us to make sure that we're using the right language and that we're really helping patients understand that it's about the learning that happens and the new experience and new memories that you can form. And it's interesting because I feel like a lot of these concepts we're talking about are enhanced, that's what I'm going to call it, enhanced ERP, right? It's kind of like you have ERP and then you bring in these concepts, and this should happen during the ERP process. And it's really interesting because I feel like part of the like questionable rap, I guess, that ERP got lately was this thought process that people had of like, well, you know, ERP doesn't actually allow you to like have a new memory or to be able to feel confident in your understanding that this is OCD, or to be confident in yourself, that sort of thing. And so I just want to say that because I think that those are a lot of myths. There's a lot of myths about people thinking ERP means you have to live with uncertainty forever. ERP means that you're never going to know the truth, where actually like effective ERP that's enhanced and integrated and you're utilizing, you know, things like inhibitory learning and core fear work, it should get you clarity. It should get you freedom. You should have total confidence and ability to understand, this is my OCD, this is not me. And so I thought that was really great. I really was a big fan of the recent one with Callie Werner on language that we use, just because I feel like that's what's really resonated with me lately. I have to tell you guys, y'all know this, but I've been doing advocacy work for forever. And a lot of times people will use some of my old quotes and they'll like talk to me about them or tag me in them or whatever. And I cringe sometimes at like the language that I used to use, where I talked about like this being my struggle forever, or this being like something I would always have to deal with, or knowing that like I would never be cured. And again, I understand why some of us are hesitant to use the word cure, but at the same time, I always wonder, like, does that make people think that you're going to have to live with OCD forever versus being able to live life however you want despite having an OCD diagnosis? And I think those are two very different things. And so for me, the language is really important, and it resonates a lot for me of like, man, I didn't use the best language. I need to get better at that. And how do I make sure that we're helping people understand and have hope for what treatment can do in your life and the changes that treatment can offer to you and provide to you, versus people thinking that treatment gets us to function and that we'll still always be struggling or suffering with OCD.
Yeah, no, I mean, I think that's a big one. And I also think it's not helpful. You know, when the older language that I came into after my treatment, and I was really excited, I was really hopeful, I was really feeling like, look, I'm doing really well and this is going to continue to get better. And I remember just getting bombarded with messaging of like, this is a chronic disorder, you're always going to have it, you're going to have to learn how to manage it. And just for me personally, it brought me down, and it actually, I think, hindered my recovery for a little bit. And it wasn't until I was like, well, you know what, I can't control that aspect of it, but I can control how much I get better. And I kept pushing and pushing. And so I really did like the live with Callie as well, just the discussions around like language and hope. And people need that. I mean, you know, I was watching a live stream that Alex and Chrissy Hodges did on Instagram, and it's like, people need to hear that people get better. I think if the messaging is always like, well, you don't get better. I think the other messaging too is like, it's okay to still be in therapy. It's okay to do compulsions and work on it. It's okay. But the mindset doesn't need to be like, oh, this is hopeless, I'm dealing with this forever. I always tell people, like, you know, people that get better, sure, if they have a thought here or there, but their life is completely different, light years different. So I did like that live stream as well. And I think the other thing that I've seen in like questions and comments that we could talk about too, or maybe do a live stream on, is rumination. I think that one comes up a lot in like the questions from people watching. And I think it's good that people are learning, like you can get better from OCD that is more internal. You know, if your obsessions and compulsions are all mental, you can get better as well. And so I think that's a message to put out there too. Sometimes people, if their OCD is more mental, they think that they can't get better if they're not doing overt compulsions. And so I saw people in the chat, I think during Callie's live, were like, no, you can still get better too. So even sometimes when we don't talk about it, our supporters in the chat sometimes help people out too, which is awesome.
Yeah, I was reading all the chat. If y'all saw me looking over a bit, so many people were talking about just like their favorite live streams, which I love hearing. So I would love for y'all to tell us, what are your favorite live streams that you've seen lately or that you rewatched lately, but also what live streams do you really want? We want to hear about that. So tell us a little bit about questions you want answered, live streams you want, guests that you would love to have on. Tell us, write that so that we can schedule that, because that's really why we do these events. I love the comments and feedback. A lot of people enjoyed the core fear work, Chris, and felt like it kind of helped them take treatment to a different level. As some people are saying that, you know, they're at a place in therapy where they don't have that much to talk about. And that's just so amazing when you get to this place where therapy is like a check-in and we can always find stuff. But I recently had a session with someone who had been seeing me for a little bit, and she came in and about 30 minutes in, I was like, so can we point out that we haven't talked about OCD yet? She's like, yeah, I know. And I was like, that's amazing. Like our work here is kind of done, right? You have other stuff in life that's coming up and that you need support around, which is great, but your OCD isn't primary anymore, right? You're not coming in these places where we have to talk about OCD and it has to be the focus, because you've done that work and you know how to keep doing that work. And that's just incredible.
Yeah. And to add on to that, I always think it's helpful too. Like I point out with clients for sure, I'll say, you know what, we are talking more about your job and your girlfriend and things like that. And the reason I think it's so important to point those things out is the more that people build their life up outside of OCD, the harder it is to want to go back. So people, I always think of it as part of the response prevention. It's like reintroducing yourself to the things that either you were doing prior to OCD becoming severe, or what are things that you've always wanted to do. And so when clients are like, hey, I can't meet next week, I'm going to be traveling, I'm so sorry. I'm like, please don't apologize. I'm so excited you're traveling, because I know that wasn't something you could do prior to treatment. Or if clients, I had a client that, because my Wednesday group landed on Valentine's Day, and I had clients texting me like, I can't make it, I'm going on a date. And I was like, good, I'd rather you go on a date if that's where you're at in your recovery. So I always think that those are the great stories to hear when people are focusing on life, and not always having to focus on OCD. And if you're still in the point in your recovery where you are talking about OCD the whole session, that's okay too. We're just telling you that you're going to get to that point one day where you're navigating with your therapist more about how to kind of get back into life versus OCD specific conversation.
That's right. Amen. Okay, so let's hop into some questions. Some folks are saying that they've been struggling with OCD for a long time and talked a little bit about some of their favorite live streams, but we are going to hop over to Tracy at 12:09 your time, Brendan. And Tracy said, Brendan, I don't know if you see that one, but it, where did it go? Guys, it left me. Here's what happens. Okay, here we are. What about BPD traits along with OCD? Is treatment the same? So BPD is borderline personality disorder. And we find that a lot of individuals with OCD also have a comorbid personality disorder. And what we know is that this is really important to understand, to be assessed for. So we've talked a little bit about this before, Chris. We did a live stream on comorbid diagnosis, and we talked a lot about how it is so important that we don't label things as OCD that are not OCD, because we really want to be able to do effective treatment. And if someone's living with borderline personality disorder and OCD, we want to make sure that they're getting the effective treatment for each diagnosis, but we also want to make sure that they have a good understanding of what symptoms are my OCD versus what symptoms are my BPD. Because at the same time, even though sometimes they can look very similar, the treatment should be very different, and the way they impact you is very different. This also goes for many other comorbidities. I talk about this a lot with PTSD, right? PTSD symptoms can often look like OCD. If someone was a victim to a break-in and they develop PTSD, they could develop checking symptoms and reassurance seeking, right? Things that look like OCD, but they're actually better explained by their PTSD diagnosis because of their trauma. And so I always love to take like a whiteboard I'm just going to pull mine out. Not that I need to, but so I won't do that. But I always like to take a whiteboard and kind of draw a line and say, okay, what are your different symptoms? And let's help differentiate what category or bucket they fit in. And so for borderline personality disorder, it's a personality disorder. We see a lot of individuals with comorbid personality disorders and OCD. So I'll label that as like, what are interpersonal struggles versus OCD struggles? And I'll take a whiteboard and we'll kind of say, okay, what are all the things you're dealing with? And somebody might say, well, I am really disgusted when a family member, does this thing and it just makes me really mad at them and angry and I get frustrated with them. And it might be more of an interpersonal kind of thing that's centered around disgust, but that if you didn't know, it might sound like OCD. And I might say, okay, that might be more interpersonal, but what are some of your OCD symptoms? Maybe it's something like, well, I'm afraid if I touch a doorknob, I'm going to get a disease and die, right? And so it's more of like, there's very different, right? Remember, criteria for OCD is that OCD tends to be irrational thoughts. So they don't make a lot of sense. They're kind of bizarre in nature. They're a little bit strange. Where interpersonal, it's more of like, oh, that thing that person does disgusts me. And I really don't like them doing that. Right. And that might be more of an interpersonal challenge, or interpersonal, like personality disorders, right, might be very rooted in like a fear of abandonment, or the fear of like feeling invalidated. Versus OCD, it might be the fear of getting a disease, or the fear of causing someone else to die, or the fear of not going to heaven, right? These they're very different in the way they present. And so anyway, I like to take a whiteboard and say, okay, what are the differences? And then how do we treat each? For personality disorders, there's different modalities that are effective interventions. For borderline personality disorder, DBT, dialectical behavioral therapy, is our most evidence-based intervention that we use for BPD. For OCD, we actually use ERP, right? Exposure and response prevention is the most evidence-based and researched intervention for OCD. And so we want to be able to differentiate those so that you can understand, oh, this is my BPD versus this is my OCD, and here's how I might treat it differently.
Yeah, no, the only thing I'll add is the biggest one that I see confused is dialectical borderline personality disorder and relationship OCD. Sometimes that's where people are very confused about which one is which. And what I always say is, remember, OCD is something where you are afraid something is happening, or you might think something is happening, but you have some clarity that this might be the OCD, where somebody with borderline personality disorder is feeling abandoned. I mean, they're feeling like their partner is abandoning them. That's causing a lot of discomfort. A lot of times BPD, not a lot of times, almost always, comes from trauma as part of the diagnosis, and people have experienced like a traumatic past. And so they will feel like they're abandoned. They'll feeling like they're dismissed, and that causes a lot of distress in them. Versus somebody with OCD is like, I know they didn't text me because they're at work, but it's causing me to feel like maybe the relationship is over and I'm getting anxiety. And so just like Liz was saying, it's really important to parse out the differences. And I always tell clients when they have co-occurring disorders, it's almost like you're going to have to learn two languages, like, become bilingual, because like you said, the treatments are different. So you wouldn't want to do OCD based treatments for borderline personality disorder, and vice versa. You wouldn't want to do as the dominant modality, DBT for OCD.
That's right. And again, there are a lot of programs. So Lauren Wadsworth runs a IOP that integrates DBT and ERP for OCD treatment up in New York. Katya Moritz over at MBI really specializes in that intersection, as well as John Hirschfeld, who's at Shepherd Pratt, right? So there's a lot of folks and John actually just wrote a really great workbook for OCD and using DBT. So there's wonderful resources out there, but it's important to know kind of what's the difference, how do I treat them differently, and what does that look like? Because DBT is a different modality than ERP, which falls within the CBT umbrella. Great question. All right, so let's move on to the next question, which was at 12:11 your time, Brennan. I'm a trauma survivor, so I don't have good emotional regulation. Therefore, I struggle with ERP since it requires that. This is a great topic for us to talk a little bit about. And Chris, why don't you kind of take that on? So I'm a trauma so somebody's saying that ERP is hard for me because my emotion regulation skills aren't really strong. What should I do?
Yeah, I mean, that's one thing to always think about is somebody that has gone through trauma and they have trauma, and especially if the trauma hasn't been worked on, there is going to be less emotional regulation, and ERP is asking someone to feel dysregulated. There's a couple of tactics that you could take. I mean, one thing that I always work with clients is, are they seeing somebody, some clinicians treat both, but are they seeing, if not, are they seeing someone specifically for trauma? Because that's important, because a lot of times there's an overlap, similar to what Liz was saying earlier. So the first thing I would do is see if somebody's getting some help for the trauma. Second of all, like what I do in my own treatment is I don't jump into ERP. And I think that's something Liz and I have talked a lot about on these streams, because some people have said that ERP hasn't worked for them. It's absolutely too difficult. And one of the things that I make sure is the person at a place that they can handle feeling some dysregulation? If not, that's going to be important. I've been fortunate that a clinician that worked at the center that I work at came from a DBT center and taught all of us DBT. And I've been very interested in it. I really like John's book that talks about both. And so before jumping into ERP, I'm going to make sure that somebody's addressing the trauma. So it's not kind of, the OCD treatment isn't re-traumatizing them. That's the last thing I want. I want to be trauma informed. And second, I'm making sure that the person is getting some DBT emotional regulation skills. So by the time we do get to ERP, they don't feel like they're going from 0 to 100. They feel like they have skills to keep them cool enough. And lastly, that's why treatment should always be collaborative. It should always be at a pace that is comfortable for the person. And what I like about the inhibitory learning live stream is the goal of treatment is not to get somebody so anxious that they can't, and then just getting used to it. Like, the treatment is a teaching tool. So if somebody is in pure terror and panic, they're not going to learn anyway. So the treatment is meant to do it in a way that the person sees value in the exposures and they can learn from the exposures.
Totally. Yeah, could not agree more. And I think it's really important to know that we do want you to have strong emotion regulation skills before you do ERP, but also know that most people with OCD struggle to both regulate emotions and to have high distress tolerance skills. Most people with OCD have low distress tolerance, which is why their OCD is so symptomatic in their life. Let me explain that. But like, if you have really strong skills around distress tolerance, in the sense that like anxiety doesn't bother you, you're able to not respond to anxiety, you're able to tolerate it, you probably won't be responding to your OCD fears. They're irrational, they don't make sense, and they wouldn't pull you in as much if you already had these strong skills around that. And so I say that just because I want you to know that ERP treatment should also teach you how to build up a tolerance to distress, right? We are trying to teach you that anxiety is not dangerous, that you don't have to respond to it. And in the famous words of Kim Quinlan, that you can do hard things. And so part of our entire model for OCD treatment is building up distress tolerance skills, right? It's learning how to tolerate distress so that you're choosing not to respond to your distress, which is also your OCD, and instead choosing to respond to your life, which are your values, right? That's the goal of treatment. But if we know that, for example, when you get distressed, you might have urges to self-harm, or you are screaming, or you're unable to really sit through it and tolerate the anxiety at all, we're going to recommend something like DBT, where you can get some sound distress tolerance skills first, so that then you can do OCD treatment, right? One of the questions we get all the time is, why do people have to be sober before treatment if a lot of the reason that people are not sober is because of their OCD? And the answer I typically give is that, well, number one, learning can't happen if you're not sober. So if you're not sober, I'm not going to be able to teach you ERP skills. But number two, if you are not in a place of sobriety, typically when people who have a substance use disorder are feeling really distressed, they end up using substances. And ERP treatment is going to make you really distressed. That is actually the point of treatment, is to make you distressed, allow you to sit through that distress, ride that wave, and choose to not respond to it. But if you don't have sobriety skills, it's going to be really difficult for us to be able to dysregulate you, and for you to not just be able to tolerate the dysregulation, but to not end up using substances. So all of those are really important things to just think about. Okay, I talked a lot and I needed a breath. So yes, OCD can come in so many forms, and a lot of you talked about kind of how it can shift and what that might look like for many of you. So many people talking about how you've had a significant reduction, but you might still hang on to some control, and how that can be white knuckling. People are talking about DBT for BPD, all of the above. So yeah, this is so great. I love y'all's comments. Love going through it.
Somebody said they loved the Marisa Mazza rather ACT live stream. I totally agree with that one. I mean, I think for a lot of people, ACT can be a softer, if it's added to ERP, can make ERP feel softer, which kind of adds to the last question. But that was definitely a really good live stream as well. I agree.
Totally. Let's hop to the question from Liz Nact at 12:22 your time, Brennan. Exposure therapy doesn't seem to work for me. Could this be because I developed OCD at 50 years old? Chris, I'm going to let you take this one and then I will add on.
Yeah, I mean, what I would say is a couple things is like I've worked with people, Liz, that were in their 80s that got better from exposure therapy. I think what's so difficult is ERP seems easy, and I think clinicians that learn it are like, oh, this is really simple to do. All you have to do is just have a client touch something they don't like, and then they learn to get used to it. It is not that simplistic. There is so much that goes into it. So, for instance, Liz McInville, not you, Liz, asking the question, and myself, I mean, we've gone to so many conferences. We keep reading new books. We go to trainings. We learn stuff about it. I mean, ERP is the core and frontline treatment, but we're also utilizing so many things. We've talked a lot about DBT today. There's ACT. Some people, need a more cognitive treatment and need it to slow down a little bit. Some people need motivational interviewing just to be open. And so if I'm working with someone, I think what is unique, and I'd love for you to weigh in on this, Liz, I think about this all the time, is a lot of the clients that come and do an IOP with me, so intensive outpatient program, a lot of them have had ERP before. And when I talk to them, it wasn't necessarily it didn't work. They just didn't have the right level of care. And so when I'm able to be with them for 3 hours, we're really able to go deep into like the pre stuff before we get into ERP. And then it's collaborative, it's values based, it's done slow. So what's always hard when we get these questions is I don't know what kind of exposure therapy you've gotten. So I don't know if it was really good treatment, et cetera. So that's, and I don't know if there was other modalities that could have been used in conjunction with ERP that would be really, really helpful, that you didn't get as well. But I will say is like one challenge that's unique for somebody who's had OCD for longer is obviously there's a lot of rituals and there's a lot of years of habits being formed. But like I said, I've had people that have gotten treatment all different ages. Their onset was later. Sometimes with women, their onset could come through pregnancy or through hormonal changes through menopause. So sometimes people have had it later, but I've never seen somebody not be able to do ERP because of age. I've just heard more so. It's like what I hear a lot is the client will say, they kind of got some psycho ed, and then on session 2 or 3, they made the hierarchy, and then they started doing exposures 3rd session, and they were like, it felt too fast. It felt like somebody threw me in a game, and I didn't even know how to play, and I just didn't find it helpful. And that's what I hear more so than age or anything. I don't know how you feel, Liz.
Yeah, I totally agree. I think there's a few factors. Number one, I think that if you're getting a really great dose of ERP and you're not responding, you should be talking to your clinician and a team about what's going on. We do have some patients that there could be something else going on, right? We want to rule out some neuro stuff. We might need to do a neuropsych assessment. We want to rule out if there's any sort of current medical diagnosis, right? Some other things that might be going on. If there was truly a sudden onset of OCD at age 50 and no OCD prior, that is something that raises a little bit of a red flag for me that I would want to rule out other things and consider a neuropsych assessment. If it's that, oh yeah, I always had OCD, but it was more at bay, but then at 50, it kind of got worse. That's very different, right? It might be more traditional trajectory. But again, it's just about having a conversation and figuring out what's going on. If ERP isn't working, I want to know why isn't it working? Is the learning not sticking? Is it that you're not doing ERP all the way? You're doing exposures, but you're still ritualizing, right? What is going on that's stopping it from working? That's going to be really important to know. But if it isn't working, we need to think about other treatments and other modalities that might either get it to be able to work next or that could replace ERP for you. So just want to be thoughtful about all of that.
Yeah. And
but there is no age that ERP is too late to work. Like we also treat geriatric patients that are 80 years old, getting good treatment for the first time and get their life back. So age in and of itself is not an indicator of whether ERP would work or not.
And Liz, like one thing, like an example, just a clear example. I had a client that came in, this was a couple of years ago, but they were saying, look, ERP doesn't work for me. I don't want to do it. And I'm like, that's fine. Like we can do other things. But as I was talking to them, their OCD was around harm and fear of snapping and harming their child. They had never gotten talked about with perinatal OCD from their previous clinician that knew ERP, but there was no discussion on that. And then they really did have this belief that people could just snap, like that was something that happens, like people just snap. And so I was like, where'd you get that from? And they're like, oh, there's a TV show called Snapped on I think the ID network, where it's about people that just snap. But we watched a couple episodes together, and it was definitely not that at all. What it was, it was like years of the wife being very frustrated and then, unaliving her husband. And I'm like, that's not really what your OCD, that's what rationally we got from that show. But what your OCD got is, oh, people snap and kill, and now you're afraid. So for us to just kind of like slow down and find out where she got that belief from and how she was kind of just like going off of errors. Then when we got to ERP, she was way more willing to do it. She's like, okay, now I realize that people don't just like snap. They're not happy one moment and then murder their whole family in the second. And so we introduced knives, and then we made it values-based. She really wanted to cook barbecue, so she cooked barbecue for her family. She used knives to cut it up and serve it. And then when nothing bad happened, she learned through inhibitory learning that everything was fine. So my only point is, I get a lot of stories like that where ERP isn't working for people, and we talk about it and it was too rushed. There wasn't a lot of education. Like I said, one of my clients said it felt like being thrown into a game with no instructions, no rules, no coach, and it was just too hard. But by slowing it down and doing ERP at a better pace, at a higher level of care that people with more severe OCD need, it was helpful.
Totally. Next question from Erica at 1222, Brendan. With trauma, I've noticed there are a lot of people in general that are becoming more paranoid with current life events happening. How does a person with OCD and CPTSD determine what is rational versus irrational when there is a lot of people around you that are feeling scared and confirming those intrusive thoughts and trauma responses? These are people without a mental health diagnosis.
Yeah, a talk that I did recently was about what happens when OCD latches onto something real. We were talking about in my groups. I know we did a live stream about it, but the thing is that's difficult is OCD is not always going to be magical thinking where you feel like if you don't watch the movie at 10:10, your whole family is going to get sick, right? Most OCD will latch on to things that are happening around us. And so current life events, whether it's a loss of a family member, whether that it's a recent break-in on your street, whether it's political, people do worry and concern. I think that's something we got to remember is people without OCD do have concerns themselves and do worry. The problem is when we have trauma and we have OCD, those events are going to cause a way different experience for us, whether it's more cognitive, repetitive thinking, maybe from the OCD, or the pure terror factor, or the feeling of like not being in control, or the fear of bad things happening because of the complex PTSD. And so we don't want to pretend like those things aren't real. That's not the treatment, is to gaslight you to think that the real events happening around you aren't triggering or are difficult. What we just want to look is like, how is OCD and PTSD adding on to it? How is it making something that is difficult but manageable to something that isn't manageable? So a lot of times what I'll have clients say is like, okay, it makes sense that you're worried about that. There's 2 break-ins in your neighborhood and that's caused you a lot of fear. How are you responding to it? And how are the people you live with responding to it? Let's look at that. And typically they're like, I'm thinking about it all the time. I want us to move. Like there's a lot there. And so that's where the treatment comes in, is like, it's not that it isn't rational. It's just, how is your response to it kind of elevated compared to something that like a range of normalcy that most people are. The only time you want to determine what's rational versus irrational is sometimes OCD is completely irrational. Like the fear of like, if I drive near a car that's red, I'll get in a crash. But most of the time when people's OCD latches onto real life events, it's not that it's irrational per se, it's just our response is heightened.
Yeah, and what I want to say too, again, this goes back to what work have we done? If we still have work to do, we're going to be scanning for the next trigger. We're going to walk around anxious about what we might hear, what we might encounter, and if we should respond. Where if we've done our work, we should actually be able to tolerate even other people's anxiety, and we should be able to clearly see it as their anxiety. But if instead we have anxiety about their anxiety, or we get worried about like, now do we need to respond? Now do we need to be worried? What I would say is you may still have some work to do, both in OCD and PTSD. Both are very treatable conditions with amazing results. And so with effective treatment, right, for For PTSD, the effective interventions are cognitive processing therapy, prolonged exposure, or EMDR. And for OCD, the most effective is ERP with a combination of medication. But if you've done the effective work, you should be able to kind of see them for what they are, of like, oh yeah, like that feels like that's your anxiety, or that feels like that's out of the norm, versus being like, am I gonna latch onto this? Am I gonna be triggered by this? Or I hope I don't have to encounter that. That might be an indicator that there's still some work to do, some of that core fear work, right? Whether it's around trauma or OCD. Next question at 12:23 from Amy. How do you know if measuring food portions is OCD related?
Yeah, Amy, I think it always comes back down to like, what is the motive behind it? So for instance, like, let's say you have, I would think of it as like, let's say you're have a health condition, right? So let's say your doctor wants you to eat less salt. So you start to kind of measure food portions, you look at the salt content in your food, you're tracking it, things like that. That makes sense to do it. Let's say somebody is a wrestler and they need to hit weight for their next competition. So they're measuring food, making sure it's the right amount because they have to make weight. Like if there's a reason behind it that isn't OCD related, totally fine. I always remind my clients, I'm not trying to make you live a lifestyle that I want you to live. I want you to live the lifestyle you want to live, but let's look what's behind it. Now, if somebody's measuring food portions and there's a fear behind it, there's no flexibility, it's not a preference, it's not a guideline, but it's a pure fear, then definitely we would want to look at if it's OCD related. I don't know specifically why you're doing it, but a couple things that can sometimes happen is there might be an eating disorder component where somebody's measuring portions because they want to stay under a certain caloric intake because of weight. Sometimes it could be because of body dysmorphic disorder. They feel that their cheek and face structure is wider, and if they portion their food, it might look thinner. And then sometimes it's OCD, like maybe they have certain numbers or certain, foods have to be separated on the plate because it can't cross because it causes some disgust feelings or contamination. So if you want to put in the chat why you're measuring food, we'd love to help you further. But in general, you'd want to ask yourself, why are you doing it? And if it's a fear-based and a rigidity and you wouldn't be willing to make a difference, or a shift, then I definitely think that would be OCD.
Yeah, again, I always want us to think about what is the function or the reason of the behavior, right? Behaviors can look like OCD that aren't OCD at all, and behaviors that may or may not look like OCD can be completely OCD. So it's less about the behavior itself and more about the reason why, right? The why behind it. Love all of y'all's comments, and it says, and eating same foods in the same order. So again, I think why do you eat same foods in the same order, right? Is it because that's your preference? Is it because that's how you want to do it? Or is it because you're afraid you're going to get sick and you have a fear of vomiting, which in that case would feel more like a emetophobia and fall in OCD line. So just really, really depends.
Can I add something real quick to that? Stacy had made a comment in the chat about potentially doing a live stream on the difference between ASD, so autism rigidity, and OCD. And I think that would definitely be a good live stream, but this is a good example. So like my nephew has autism, for instance, and I have clients with autism, and they may eat their food in a certain order, and I'll ask them why they do it. And they're just like, that's how it is, right? There's no fear there. That's just what makes them comfortable. And that's how they eat their food. That's fine. Once again, like Liz said, function. So that's the difference, kind of just to tap into what, Stacy was saying, is like somebody with autism may be a little bit more rigid that way versus somebody who is doing it because they feel like if they eat the wrong food in the wrong order, something bad might happen, or just right feeling.
I was hoping that I had John Hirschfeld's DBT book, but I don't know, it may be up there or not. But someone asked if we could recommend a specific book on emotion reg for OCD. John Hirschfeld wrote a great book. We can drop the link in the chat in just a second on DBT for OCD. So like DBT and emotion regulation with OCD. So we will drop that in there. Gabriel at 12:25 said, can an appropriate meditation work as a tool for OCD? And I'll take this one quickly, but the answer to that is yes and no. So meditation, eating well, exercise, that can put us in a certain headspace. That can be a really useful tool for our mental health in general and to decrease our vulnerabilities. And it might be a practice that we love to get back to for ourselves. And it's a values-based activity. Meditation, eating healthy, exercising in and of themselves are not treatment for OCD. So it's not going to necessarily reduce your OCD symptoms, but it might reduce your vulnerabilities to make you more willing to do ERP, or it might be something that's important for you to get back to as a values-based activity as a part of treatment. But in and of itself, they are not treatment, if that makes sense. Next question from Cheryl at 1226. She says, my son has contamination OCD. He will not touch food to prepare a meal. How would you start ERP in a residential treatment if you have to prepare meals yourself? This is a great question. I'm happy to take this because we help I run a residential OCD program. So, this is where we really are going to help support the patient. So at our program, for example, patients are asked to prepare their own breakfast and lunch, and then we prepare dinner. And that's intentional because imagine if a patient came here and never prepared their own breakfast, lunch, or dinner and had to go back home and do it. You'd be like, well, that wasn't a very successful stay at the program. And so it's an intentional piece. With that being said, all residential programs should have 24-hour staff support, and they should be willing to help. And it should be a stepwise process. We might not expect the patient to prepare their own meals day one, but we would help them preparing meals until they can. For a lot of our patients, they'll start with frozen meals and things that they feel like is less challenging for them to be able to heat up and not have to touch, but to prepare on their own, and then work up to preparing meals for exposures.
Yeah, Liz said at 12:29 exactly. They rushed right into ERP. That's why I think, Liz, what it might be time for is a live stream on just like what are some of the top 10 errors in doing ERP, whether it's for therapists that are new to it or for people that are getting ERP treatment. Like, what are things that you should be doing versus what are some things that might be traps? And I think, Liz has talked about it a lot on here. It's like you may have to, as a clinician, not do ERP for the first 6 months. If that person is still in the contemplation stage, they're still really stuck and triggered, forcing somebody into it is not proper. So that might be a good live stream.
Totally. And so somebody asked if Marisa was a part of the team that helped Ethan. Ethan was helped by Katya Moritz and NBI, and then Marissa Massey, who he talks about openly, but a different M, similar names, Marisa versus Marissa M, but so happy to hear y'all love that live stream. Some people asking questions about medication. We've done some amazing webinars on that. And you can also go to iocdf.org to learn more about the latest recommendations, advice, feedback, you name it, on medications for OCD. Next question at 12:31 your time, Brennan. Any tips on helping our son with contamination OCD and high level, please?
Yeah, real quick, Brennan, put a note. We need to get a psychiatrist back on here. I just looked, our medication questions are piling up. So we will get a psychiatrist on the live. Okay, so contamination OCD, and if it's high level, I'm a big supporter of like the right level of care. So what I always tell families, because I run a family and loved one support group, and family members will be like, okay, we're trying to get him into a therapist for once a week. And I'll say, okay, tell me a little bit about how the contamination is impacting your son. Oh, he hasn't eaten in 2 days. He doesn't leave the house. He can't eat certain foods. Seeing somebody once a week at that level is not going to be helpful. They probably need a residential and then eventually a step down PHP or IOP. So that's what I'd say first, Celeste. If your son is really, really, really severe, low insight, really struggling, because what I always worry about is if somebody goes into once a week therapy when they're that severe and they see no progress, then in their mind, they're like, OCD therapy doesn't work. Yeah. And then they're going to be less likely to do it. So
therapy doesn't work for me. That's our most common phrase that we hear. And it's disappointing.
Yeah. So that would be my first, is make sure he gets the right level of care. And any ethical clinician, like even though I run an IOP, I tell plenty of clients that do assessments with me that we are too low of a level for them. I refer a lot of people to Liz. They're the closest OCD specific residential, because I don't want them to come to the IOP, not have a good experience, and then not want to do treatment. As for second, Celeste, is like when somebody has contamination, their brain works differently about contamination. They think things can spread. They think things can last on things forever. They get a gross disgust feeling. They think they might get a disease or a virus. There's a heightened fear. And then what they use to kind of prove that that's okay to feel that way is because they're like, there are viruses on things. COVID is a real thing. People do get sick, etc. People get sick from water or from food. So there's all these reasons that they verify that it's real. So what a clinician is going to do is it's going to help the client not become a dirty slob. So your son isn't going to go to the other extreme. It's simply just to recognize, like, how has he lived his life in a way that he thinks he's keeping himself safe, but he's added on loads and loads and loads of mental and physical compulsions that are actually not helpful. And so as a parent, if he's in a place that he's just not able to reach out and make an appointment himself, find a treatment provider, set up the first appointment. And like I said, an ethical clinician will do an assessment and say, hey, this is the perfect level of care or higher level of care. But as a parent, the best thing you could do is provide your son with education, find a clinician. iocdf.org/find-help is a great place to start.
Yep. Amen. Amen. Okay. So next, we have so many questions. We're not going to get to them all. So now I'm panicking because it's 11:46. Love all of y'all's comments and giving feedback to each other. Is there biology and links to OCD? The answer to that, Zenas, is yes, there is. We know that OCD is a neurobiological disorder. You are born with OCD. It just onsets at different times for different reasons. We don't necessarily know that, but we know that individuals are predisposed to OCD. Therefore, there is definitely a genetic component. The details of that genetic component are still being figured out. We're just not there yet with our research to know that.
I'm going to put a couple links for you, Brennan. There's an article that the IOCDF put, like what causes OCD, and I think it's good. And then there's the new, did you see that, Liz? Like OCD in the Mind, like the new collaboration that IOCDF has. So I think that might
it's amazing. That'll be such a great one.
What is it called? Because I'm trying to find it for Brennan.
Brendan's gonna have to tell us what it's called. I think it's OCD in the Mind, or Mind and OCD. One mind one. So Brendan, you're gonna have to tell us. We're stuck. Next question. I just had up that, of course, now I've lost, but I promise you guys I will find it. It's from Madeline. Where did it go, Madeline? There it is. For Madeline at 12:38, Brendan, your time. I've been through a lot of treatment for my OCD and BPD, and my OCD latches onto my family and burning out intrusive thoughts and confessing and reassurance seeking. Is there something in particular you'd recommend to help? Yeah, I'll let you take that, Chris.
Yeah, what I think is difficult with OCD and BPD together is, like you were saying, Liz, is just really telling the difference between which one is, because BPD, like I said, is I have someone close in my life who has it, and it's a lot of times they're misreading interactions, and a lot of times they're confronting me about things that I don't mean, or they're like, you said this, so you're feeling like this towards me. So it's a lot of misreading other people's emotions and intentions. And a lot of times it comes from a fear of like abandonment or being hurt. So I would say that you want to make sure the BPD is being treated. What I've seen with clients that have both is when somebody does probably BPD first treatment, if that's what's most dominant, when they get to a point that they really go through the DBT skills, they do emotional regulation, they really understand, they're in a better place that they could focus on the OCD. Okay, so you've been through a lot of treatment, OCD lash on blurting out intrusive thoughts and confession and reassurance seeking. Yeah, so what I would say is, like, we know what confession and reassurance seeking is doing. It's basically telling your rational brain, like, I can't trust you. I don't think you're good enough to assess these situations. Therefore, I need to lean on other people around me to tell me if something's okay or not. So when people ask a lot of reassurance, I was a reassurance seeker. My mom and I talk about this all the time. I would call her 50 to 60 times at work and ask her questions. And what I learned from that is that I can't trust myself. I don't have a good insight. I'm not somebody that can handle hard things. And I need my mom to kind of make me feel okay just to get through the day. And so when I worked with my clinician on reduction, right, we didn't eliminate right away, we reduced. What I started to learn is, like, as my mom's reassurance went down, I started getting to a point that I could trust things. So for instance, my fears of health related OCD, if I drove by and somebody exhaust on the other side of the street was kind of, putting up some smoke, I was like, you know what, Chris, I'm just driving by a car that has a little bit of exhaust. I'm not going to get cancer. But I didn't know that because I was calling my mom on a daily basis, asking her those questions, and then it didn't stick. It's kind of like I knew it and then it passed. So I would say that confessing and reassurance seeking, it's really hard to get better if those things are dominant. So I would probably start there, but make sure that the BPD is being managed, because it's going to be really difficult to do OCD treatment if you're finding yourself just in consistent states of just really, really difficult emotions to regulate from.
Yeah, amen. A combination of DBT and ERP. And I think that if it's OCD reassurance, you want to use OCD treatment. If it's that there's like emotion regulation, you want to use DBT, right? So again, just depends. And having somebody who specializes in both would be really important. And that does exist. So yeah, so many great questions. Love all of y'all's stuff. Questions about meds. We're going to be working on that. Alive on OCD and high functioning ASD, definitely see that note, and we'll be taking that on. Searching for telehealth that does ERP who are licensed in Alabama. I do not provide that. IOCDF you can choose by state, and then you should be able to click modalities. So that is how I would look up if there's what options are available to you, because I cannot remember if Alabama is a SIPAC state or not, because that would allow there to be opportunities for psychologists who are outside of Alabama who have a SIPAC license. They could practice in Alabama, but if not, you would just need to find somebody in Alabama who does OCD treatment. I know
Also, what I found out, because I had a client that went to Alabama, if you're licensed in California, you can see clients right now temporarily. You just have to reach out to their board. You could see clients in Alabama. Just found that out because I had a client going to Alabama. The parents looked into it, and I called their state board, and they said, yeah.
So there's that. Never know what can happen. Got through all the questions. I'm so proud of us. So yeah, why don't we end? I know you had a pre-submitted question, Chris, you wanted to get to. So why don't we do that question? It was, how often does OCD get missed? Sorry, this was not pre-submitted. I missed this on the chat. So we are going to jump to this question. How often does OCD get misdiagnosed? I was diagnosed with general anxiety and panic disorder, but it turns out it's been OCD.
Yeah, I'm glad this question was asked. I mean, I would say OCD, unfortunately, is extremely misdiagnosed. It was part of the focus of my thesis, and it was found that 60 to 80% of general medical doctors, so we know that people, when they are showing OCD symptoms, the first person they often go to is somebody who's in the medical field. So it could be a nurse practitioner, it could be their doctor. And unfortunately, about 60 to 80% of the time, they're getting misdiagnosed there. Now, psychiatrists are a lot better. It might be in the lower, like 40 to 60% range is what the recent research showed, but that still means a big amount of people are being misdiagnosed. Now, what I saw in the research is that part of the reason it's misdiagnosed is there's a huge misunderstanding of OCD. Like somebody put in the chat, sometimes symptoms of ASD can look like OCD. Sometimes kids in class that can't focus get misdiagnosed as with having ADHD, but they really have OCD. People with BPD sometimes get misdiagnosed as relationship OCD. So the problem is somebody has to do a deep dive, because sometimes these disorders have similar presentations. And then second, a lot of times people are very familiar with OCD if it's checking a contamination, but are not aware of more of like the taboo themes. So sexual intrusive thoughts, harm thoughts. They're not, they don't know a lot about scrupulosity, hit and run OCD, etc. So that's why a lot of people will get diagnosed as general anxiety or panic disorder. That's why we really push, if you can, find an OCD specific clinician to get your assessment from. It's always going to be better, because like people like Liz and myself and other great clinicians eat, breathe, and sleep this disorder. And that's what we're seeing all day. So if we have a client in front of us that doesn't meet diagnostic criteria and additionally does not show any sort of trends as any of our other clients, then we know that that person doesn't have OCD. But if somebody is rarely seeing OCD, maybe once or twice a year, they may misdiagnose. So I think that's why so many people are misdiagnosed and it takes a longer time. And sometimes their co-occurring conditions can also make it confusing, you know?
Yeah, all of the above, right? That's also true. And again, so a lot of it is based on what is your specialty, right? Even general clinicians who are psychologists or mental health providers who don't do OCD and anxiety specifically, they may diagnose it as GAD or anxiety first. And then once you get to an anxiety specialist, they might be able to say, actually, this isn't OCD, or this is GAD, or whatever it might be. But this is a very common, and again, often GAD is co-occurring with OCD. So there's also a strong chance that somebody may have both. So yeah, all great questions. And this is why specialty care is so important. Today's been so amazing. I love these chats. So Chris, just share a little bit about what you think are some really important takeaways for us to be discussing and talking about in treatment today.
Yeah, I would say first, it seems like what people really want is a live stream on ASD and OCD. I know we've done some in the past, but I always think it's good to do updated ones. And then there was a second one that I said out loud. Oh, getting a psychiatrist back on. I think it's really important to get a psychiatrist back on. I would say, like, what I always take away is I don't, I tell people all the time, like, I didn't invent ERP. I don't have it tattooed on my arm. I totally understand that the way it's implemented doesn't work for everyone. And I like things like John Hirschfield's new book about the combination of DBT and ERP for OCD treatment. A lot of us are looking at other modalities. We're taking things from it. We did that whole stream on inhibitory learning. But I think because Liz and I work in a higher level of care, we get so many people that are severe that have not found success in ERP. And then when Liz and I talk to them and we go in more depth, it's rarely somebody I've heard of. And it's not somebody that has done it in a way that Liz and I and other people that are really, study this stuff do. So please don't give up hope. Really try to put some due diligence in and make sure you're finding someone. I think if you see them on these lives, if you see them active with the IOCDF, if they've written books on the topic, if they're speaking at the conference and people are really kind of like, backing them up, that's what I would say is huge to look for, because that way you can get proper care. So those were some of the things that came up today that I think are important for us to address in the future. But I hope people got hope. It seems like a lot of people in the comments have gotten better.
Yeah, and I love you guys feeling like we are getting into the nitty gritty and details of comorbid conditions and treatment and how to kind of better hone in and do ERP in a more specialized fashion, because it just goes to show that the growing knowledge of ERP is really increasing, and that base knowledge has really changed from what it used to be, and that we get to dive in. It's so important for us to know that mental health and mental illness, it is not a one size fits all, right? And neither is treatment, because people's presentation and people's diagnoses are different, right? Some people have comorbid diagnoses, some people do not, some people don't have OCD, but they have GAD, right? And treatment should be specialized for you, for whatever you're dealing with, whatever symptoms you're presenting with, and whatever diagnosis you have. And so it's really important to know that if the treatment you're getting isn't working and you're feeling stuck, advocate for yourself to better understand what is the full picture of what's going on, and is there a better treatment that can specifically hone in on my current diagnosis and symptoms so that I can get the relief I deserve and be able to live the life that I should be living, and not a life where it is controlled or defined or ruled by your diagnosis.
Yeah, I love that you brought up Callie's live. I think for anybody that's maybe feeling a little bit down of recovery, we did a live stream with Callie Warner that Liz was talking about at the start of the hour. And I hope you guys visit that, because I know for me, if I was newly diagnosed, I think that live stream brought a lot of hope. And Callie is so like anybody that runs, maybe that's what it is. Her and Katie, they always seem so upbeat. And I always joke, I'm like, you have to be a happy person to run for fun, because every sport I ever played, running was like our punishment. And so since both of them are always like running for fun,
It's
like,
valid. That's valid.
yeah, I'm like, maybe y'all maybe y'all are happy because you have to be to run all the time. But yeah, I mean, I my heart always breaks. I mean, you probably feel this way, Liz, as well. It's like my heart always breaks, because I know there's people suffering all across this globe that aren't getting help. So I always hope that the messaging coming out of us, out of the lives, out of IOCDF, the other lives that are happening as well, is that people are getting better and people are finding hope. My mom always says when she went to the first conference, she left not feeling a lot of hope because there weren't a lot of people sharing success stories. And now going to these lives, going on Instagram lives, the conferences, you hear nothing but success stories. So it doesn't mean you're bad if you're not getting better, but just at least know that it's possible.
Totally. Couldn't agree more. Love you guys. It's such an honor to be here and to be able to share and talk together from both our personal and professional experience. And we're just looking forward to so many more. Again, please visit iocdf.org/peace of mind. And that is where you can put upcoming live stream questions you want answered, content you want us to address, special guests you'd love to have us on. We love to know that so that we can make sure we're offering what you guys want and what is meaningful to you. Thanks, you guys. Help and hope are always available.
Yeah, take care. Ramon, I got your question. We'll answer it next time. Be back next Wednesday. I think pretty soon. Somebody asked about a live stream with Robin on BDD. We're going to be doing a lunch and learn with Robin Stern on BDD to celebrate the upcoming BDD conference, which is Saturday, March 16th. So make sure to hang out with us. We'll be back next Wednesday, 9 a.m. my time, 11 Liz's, 12 on the East Coast. Take care, everyone.